Okay, I believe it's 5 p.m. Amman time. I would like to thank you all for being with us here for this webinar about some challenging surgical cases encountered in Gaza by visiting surgeons. I believe again and again and again that maybe the best people to talk about what's happening in Gaza actually are the surgeons of Gaza rather than ourselves who visited maybe for 1 or 2 months or even sometimes few weeks. But unfortunately, I don't think any of them currently have the time or even the internet connections to basically have these kind of basically webinars. They don't have the time to prepare such cases. We are all sitting here in our clinics, houses, homes, offices, and we have the luxury of time and the connectivity. Unfortunately, they are being bombed and they're dealing with this large number of casualties as we talk right now. So, I will introduce myself. My name is Osama Hamid. I'm a consultant surgeon, mainly GI hepatobiliary, trained in the United States, currently living in Jordan. I've been to Gaza twice, once in February for almost 3 weeks at Al-Aqsa Hospital in Deir al-Balah, and a second mission in June, July for a month in the north of Gaza at Public Aid Hospital in Gaza City. Our panelist with us today is Dr. Hani Al-Qadi. He's a consultant general and trauma surgeon from Muscat. He's the head of trauma in Sultan Qaboos University Hospital. He also was my co-pilot and co-surgeons during our mission in Public Aid Hospital at Gaza City for 1 month. And we have also Dr. Bushra Uthman. She's a surgeon, general surgeon with colorectal interest from Melbourne, Australia. She also was at Gaza in both Nasser Hospital, European Hospital, and Al-Aqsa Hospital in June, July for a month. We have Mike Mallah. He's also a trauma surgeon that also served in Gaza at the European Hospital, and he made such great impacts in international media, meeting at CNN and other international newspapers. And then we have Usaid that he just told us he can't actually join us today for some family issues. I just want to make sure some introductions. I will be moderating and let Bushra and Hani present, and then I might also present if there's some time. That the importance of these webinars, I believe, because we are actually the actual eyes for the international communities. As you all know, none of the international news agencies were able to get into Gaza, and a lot of people are actually depending on us as surgeons who were in Gaza to provide some eyewitness, basically, eyewitnessing what's happening and describing to the world, relaying the message. We are concentrating here on a scientific community, but I believe it's very important to continue providing these piece of information that actually helping our people in Gaza by showing the world what's actually is happening in terms of what's the ongoing genocide, number of casualties, type of injuries, the actual healthcare system that we all aware of. My interest started actually in January. We were all sitting watching this new news, watching these people getting killed and injured. And at that time in January, none of the surgeons were able to get into Gaza. I know that the first mission was late December. And then I arranged this webinar back in January 28th with Dr. Ghassan Abu Sitte, that he could not attend for some reasons. And what ended up, we had a speaker, Dr. Khalid Sir. He was live from Nasser Hospital. He's a surgeon from Gaza at that time. He had very poor connectivity, but I believe the whole webinar was based on Dr. Khalid Assir live cases of what's happening in Gaza in that particular time. It was January 28, 2024. Based on this webinar, actually, we have created a WhatsApp group for helping Khalid deal with some complex cases, basically that he was dealing with. He was just a freshly graduated general surgeon, and he has to deal with so many complex cases at that time with no help and support. He was at Nasser Hospital at that time. And actually, based on that webinar that we started with Khalid, and then the WhatsApp group that we created, and then we did some sort of global telemedicine initiative. This webinar has translated into this paper in The Lancet that was just published last month. And you can see the lead author actually is Khalid Sir, that has been abducted by the Israeli army in I believe February or early March. And since then, nobody knows exactly where he's at. Last thing we heard from his cousin Usaid, that Khalid is at Ofer prison, and the only thing that he did not leave his patients at Nasser Hospital when the Israeli army actually invaded Nasser Hospital and destroyed Nasser Hospital. So don't underestimate anything you do for the people of Gaza to show the world what's happening. So this is a general surgeon who we had with us on a webinar in January, got abducted because he refused to leave his patients when the Israeli army asked for everybody to leave the Nasser Hospital. And since then, he's been abducted. And again, that had translated into this paper that basically global telemedicine initiatives to help people, surgeons of Gaza, and describe some 12 cases. This is published in The Lancet a few weeks ago. We did another webinar in April 7th after my first mission with my friend Abdullah. He was an anesthetist with me. And at that time, Dr. Hani Al-Qadi and Dr. Kaali was both panelists. And based on this webinar, actually, Hani was so excited to come and visit Gaza. And now we had another initiatives, basically another advocacy surgeon to advocate for the people of Gaza in Oman and in the trauma community. And also based on this webinar, multiple people got excited and wanted to go and help the people of Gaza. So don't underestimate what you do. Everything you do, eventually, I hope it will translate into something meaningful to the people of Gaza. So Hani was there with us on this webinar, and actually he was my co-pilot in my mid-June and July mission, and we did more than 150 cases of complex injuries. So what I'm proposing here, and I think Usaid just joined us, is for the general and trauma surgeons in Gaza, why not to do this kind of consortium and try to really provide some sort of online group. The main things is to try to pull data together for future publications and evidence for the court, international court, and any things, and hopefully for meetings and presentations, and also work as a professional and psychological peer support group, because I'm sure everyone who was there, you get so much psychological trauma that I'm still myself trying to go over, and I just can't. So that's why I'm trying to go back again next month. Just to sum up things finally before we start presentations, this is according to from today the WHO last data. We're talking about 41,272 fatalities. Majority were children and basically and women. Still, we have more than 95,000 injured and 10,000 under the rubble. Very interesting paper also published in The Lancet, basically stating counting the dead in Gaza, difficult but essential. So they got into an estimate because of the destruction of the healthcare system, spreading of infectious disease, spreading of the destructions of all infrastructures. So the estimated death toll for every one direct death from the injuries, there's 4 indirect due to cancer death, cardiac attacks, basically other infectious disease death. This is actually basically a very low estimate, because based on previous works, the ratios was as low as 1 to 3 to as high as 1 to 15. So I believe just being there, knowing what's happening there, I believe the ratio would be more likely 1 to 10. So we're talking about more than 10% of the Gaza population has been annihilated by the Israeli army due to the direct war injuries and also due to the destruction of the healthcare system that you all are aware. Before I end, I would like to again thank you all of being here, and I would leave the message to start with Bushra to present some of the cases that she encountered. We'll open some discussions, and then we'll go with Hani, and if there's more time, I can do some presentation myself. Bushra, thank you for being here.
My pleasure. It's an honor to be on the panel with everyone, and thanks to all the participants who are joining us today. Dr. Osama, do you think that I can get access to share my screen?
Sure. I will let you share your screen now. Chat, stop, make a host. Okay, I think you should be able now to share your screen. Yes.
Everyone can see that, okay?
Yep.
Yeah. So thank you very kindly for the introduction, Dr. Osama. I'm a general with surgeon down here in Melbourne. In fact, I spent 3 weeks at Shuhada Al-Aqsa Hospital in Deir and Balah between the 13th of June and the 3rd of July. And what I thought is I'd just run you through one of the patients that I thought would be interesting to discuss, as it required a lot of different teams in order to coordinate his care. He's a young 22-year-old gentleman that I'll call MAZ, who suffered an explosive injury in his home, which most of the patients that we would see, that is how they would present. He had his main injury as an entry wound in his left back and an exit wound anteriorly, with an initial primary survey that showed a FAST scan that was positive. I'll skip over some of these things just so we can try and get to the meat of the case, but essentially, there's no point sort of briefing over the initial managements, but they're the same within Gaza, other than to say that depending on the emergency department and the capabilities, you can get a chest X-ray in most circumstances. A FAST scan is able to be performed depending on who is actually in the emergency department. So there was an external CADIS member that had a portable FAST scan that would normally do that for the trauma patients. So he had an ICC in his left chest placed in ED. He went to theatre. He had an exploratory laparotomy. He had a grade 4 splenic injury that required a splenectomy. He had a small left-sided diaphragmatic injury that was able to be primarily repaired. And he had a small left abdominal exit wound that was presumably from some shrapnel during the explosion. I've just put a picture there of the exit wound. So, maybe not everyone here has seen major explosive injuries or blast injuries before, but the heat and the transfer of energy throughout tissues really causes severe destruction depending on how fast the shrapnel is passing through the body. So you can see the skin loss that's occurred over the left anterior chest, including the slight loss of bone, including muscle where that open wound is.
So can you orient us just on the image one more time? Where is the face and where is the...
Yeah, so the face is on the right-hand side of the picture up here.
Okay.
This is left-sided chest tube through the fourth intercostal space.
Okay.
And this is the left anterior to posterior sort of
This
chest
is the
wound.
exit wound or the entrance wound?
Exit wound.
Exit wound.
Yeah. Yeah. So I don't have a photo actually of the entrance wound, but yeah, okay. This is it here. Over the course of his time, he was slow to improve. There were concerns regarding poor nutrition, multiple wounds, including having had a laparotomy, splenectomy, so therefore at risk for certain OPSI infections. He's a very thin gentleman anyway, but poor ongoing nutrition in order for those wounds to heal. And there were some concerns about a possible esophageal injury. I just wanted to highlight a point about how to obtain further imaging in Gaza. And depending on where you are, that can actually be quite difficult. So at Shuhada Al-Aqsa Hospital, they have one CT scanner, which for many months some of the parts had been broken down. And so the only CT scans that were being performed were urgent CT brains. If you wanted to get a CT chest or a CT abdomen, the patients actually had to get transferred out to a nearby hospital or Jaffa hospital in order to do that. There was some capability in terms of providing both IV and oral contrast, but as you can imagine, it's not on site, and there needs to be sometimes some clear directions, which there's a huge potential for some miscommunication. There were some locules around the esophagus, only a few of them.
Buthayna, sorry, Bushra, just one thing
Yeah,
is, so you have to send the patient to another facility to get
yeah.
a CT scan. So there's no CT scan available inside. And my understanding is that that happens only once per day. So you don't have the luxury to send it anytime. So you can't send the patient to get CT scan anytime. It should be in certain particular time of the day. Is this correct?
Yeah, so between 8 a.m. to 2 p.m. most days is when Jaffa, the hospital in Jaffa, would do CT scans. Outside of that time, it would have to sort of be an urgent matter that would need to be approved. Only urgent CT brains were being performed while we were there. Since we've left, actually, the CT scanner has stopped working altogether. So now even for an urgent CT brain, there'll be an ambulance that takes the patient accompanied by either a nurse or possibly a doctor, sometimes in the middle of the night. And as we know, there's no such thing as a deconflicted route or a deconflicted zone. They could be transferring the patient for an urgent CT scan and anything could happen.
So just to clarify more about these issues, I have been involved since my visit in February about the CT scan issues. And actually, we tried to secure the piece that is missing for the CT scan at Al-Aqsa Hospital to work. And
Yeah.
it took us 6 months to get it in. So back in basically early August, we were able to get it in. And unfortunately, still we can't install it because there's still some missing pieces that needed to be basically for installation. So imagine yourself dealing with the only hospital in central of Gaza where you're receiving most of the trauma and no CT scan available because the IDF is preventing this piece of basically machines or let's say equipment to get in for some security concerns. So I believe a lot of preventable causes of death would a lot of cases where death can be prevented actually end up dying because the CT scan was not available either to make the diagnosis or to deal with complications post-operatively. What do you think, Hani?
Yeah, it is a major challenge, and I'm going to speak about it a little bit when I talk about my case. Yeah, it's appalling.
So imagine a trauma surgery without CT scan. What basically you can basically deal with. You're dealing with major injuries, no CT scans to make a diagnosis or even to help with complications post-operatively.
Yeah, like you said, I mean, not just mortality, but I think severe morbidity is definitely a key factor with patients not being able to get appropriately timed scans.
Go ahead, Bushra, please.
No problems. So there were some discussions between the teams. He didn't necessarily clinically present as someone who was maybe having a true esophageal leak that was that was causing pneumonitis or sepsis. So there were some discussions about how to best provide maybe some nutrition to help with his overall care. So we went ahead and reopened part of his laparotomy wound, reran the abdomen to make sure there was no other injuries, which there wasn't. And then he had a feeding jejunostomy performed. I just put these here as some highlights of documentation. So there's this issue constantly where paper is very difficult to obtain in Gaza, and so that makes documentation sometimes quite difficult. The operation report here is actually being written on an A4 clean sheet of paper, which is almost unheard of. Most of the time, it was very, very difficult to get clean pieces of paper like that. And then again, just to highlight for patients, so post-operatively at Al-Aqsa, they have this one corridor that is both the entry and exit to the operating theatre, and there are a couple of rooms that are the recovery rooms or where patients would sort of wait. This is our patient post-operatively. So he's in front of the nurse's desk and in that hallway. He's not attached to any blood pressure monitoring, heart rate monitoring, oxygen saturations. Talking about complete lack of supplies, his urinary catheters just being emptied into this rubbish bag here. The rails are down. If he was thrashing about or woke up differently from anesthetic, he could fall off the side of the bed. Like, anything that we're normally used to here just does not really exist in Gaza. And he'd be watched for a short period of time. And as soon as the ward or wherever he was stationed pre-operatively was available, they would transfer him back. So again, I just use this to highlight the fact that it's a completely different setting in terms of what we would normally be used to here.
And actually, I can just echo what you have said about post-operative care. A lot of these patients actually need ICU care, but after major trauma, and actually no ICU beds available. And I have myself lost a few patients because they were sent to the floor, regular floor, and no real care was provided to them. So again, the whole Aqsa hospital has only 10 ICU beds, and being the only hospital in the middle of Gaza, that would really make, again, a lot of these deaths that happens actually are preventable in the presence of well-established healthcare systems. We know the IDF had targeted hospitals, bombed hospitals, and bombed even healthcare and killed even and attacked healthcare workers. So again, that would really add to the catastrophe that we are seeing there.
Definitely. And it is a new mindset for all the visiting surgeons to get used to, because there's a lot of overload in terms of just not seeing how you would normally run surgical teams or how you'd run the operating theatre or post-operative care. And you do sort of have to be a little bit flexible in how to try to provide the best care that you can within these low resource settings. A few days later, while he was on the ward, there were some comments made by his family that he was drinking a lot orally and the NG2 had come out, and they were noticing that the chest tube was starting to have a slightly funny appearance. So there were some concerns there that, maybe he truly had an esophageal leak. He also had some rising inflammatory markers and started to show some signs of sepsis. So there was a differential diagnosis that maybe it wasn't just an esophageal leak that was initially missed or had now sort of caused a delayed presentation. It seemed a little bit unusual with maybe where the entry and exit wound sites were throughout that chest. But as we know, even 1 to 2 millimeter fragments of shrapnel can cause significant injuries that only present many days later. So there was also a discussion about, maybe this was also an esophageal pleural fistula. So I just highlighted some of these questions on my slide to have a think about, what can be simple things that we can do? What are things that are a little bit more extensive? I mean, he'd already had one CT scan. We spoke about the difficulties of trying to transfer patients to another hospital to try to get a second CT scan. We did hear that there was potentially some methylene blue that he could have, but I never saw it sort of be surface. And then I think in the end, the discussion was just that, and I'll show you on the next slide, that his chest drain output and the color was significant for us to actually just proceed to surgery. So I'll play this video here while he was actually on the operating table and we were getting ready of what was happening with his chest drain output. So, I don't know what everyone else thinks, but that's certainly not normal ICC output. And some might even say it looks a bit Kyle-like rather than it being actually true esophageal. It had an NGT placed, and you can see what sort of the NGT output from the stomach was there, and that's just his catheter in the other photo. So this is a pre-op photo that I just want to highlight. So, I mean, the defect here that I'd shown in that very original photo, I've just got a close-up here on the left-hand side image where you can see that the chest drain that was placed in our routine position in that left anterior chest, the tip of it is actually now pointing downwards, and it's visible through his wound, his open wound, all the way through that chest wall. Now, that's not going to provide any significant drainage, nor is it actually even positioned in a proper space. And this is just then to highlight his feeding jejunostomy that had sort of been placed a few days earlier with one of the other potential exit wounds from some shrapnel injury that was in that left anterior abdomen. So again, just to highlight, consent forms are sort of a bit dependent on the surgical teams and who's sort of taking consent from that. I won't go take you through that, but just that despite everything else and sometimes the documentation not necessarily being what we would consider up to par, they still do, the surgical teams there still try to maintain appropriate consent. If it's not necessarily from the patient, then it's from their family members, and ensure that that's well documented. So this was a multimodal operation between a few different teams. So Dr. Raed Al-Aini, which some of you guys might have seen in some videos recently with some updates about Al-Aqsa having absolutely no supplies. So he came to do the thoracotomy for this patient. I'll show some images in a video in the next slide about the debridement that needed to occur. There was a lower segment of the upper lobe that did have a little bit of a leak from it, but it didn't seem super significant. That part was resected. They did have a few GIA staplers, and we just reinforced the resection staple line. We did have a think about how we could test to ensure that there wasn't an ongoing esophageal injury. Again, there's no ability to do endoscopy, especially not at Al-Aqsa. There's certainly no ability to do laparoscopic surgery, especially during when we were there. I mean, we'd run out of sterile surgical gowns and abdominal packs, and then eventually gauze. So, laparoscopy was certainly not a possibility. And so the NGT was sort of just retracted to be in the proximal esophagus. We tried to distend and insert some fluid to see whether or not, after mobilizing some of the chest, whether we could identify any massive esophageal leak. Anything that might have been minor, the thought was that we would manage it conservatively. So again, it's just to have a think about that. In any other setting, you'll be able to get a gastroscope and physically have a look down the esophagus. Here, there's no ability to do that. And I'm not sure what the other panelists think, but I think potentially there was one gastroenterologist maybe at one of the hospitals somewhere that had the ability to do gastroscopy and colonoscopy. But again, that's not easily attainable. It can't be for everyone. And in an emergency setting such as this, it's again not a feasible option.
Yeah, I believe that was one of the major challenges for any GI surgeons who does even sometimes even, I remember encountering a case where there were some suspicions, 70-year-old lady, where there's some suspicion about gastric volvulus on CT scan. And they wanted me to operate on this patient for this suspicious of gastric volvulus. Endoscopy is not available. So I ended up doing the old way of testing for volvulus, trying to pass an NG tube, and actually did go through. But they would have already booked her to the operating room that this patient has a gastric volvulus and you have to operate on. The endoscopy at Al-Aqsa Hospital was not available. There were some endoscopies at European Hospital and other hospitals, but during my first mission at Al-Aqsa Hospital, endoscopy was not available. And you can imagine a lot of even patients with chronic diseases cannot be managed properly, either colon cancer screening or colon cancer diagnosis. Most of these patients end up having obstruction for their cancer before they ended up having treatment. So again, that's part of, again, what happened in the healthcare system is complete destructions, and it really collapsed the first few months of the war. And basically what we're doing here is trying to do some palliative interventions, but I believe so many deaths could have been prevented if the healthcare system, like a Shifa hospital, a Nasser hospital, European hospital, was not attacked or destroyed by the Israeli army. Go ahead, Bushra.
Yeah. So just to show you the state of what his chest cavity was like, significant inflammation, some purulent fluid, not necessarily completely stuffed down, but we did manage to do reasonable debridement. So the decision had been made preoperatively for this patient about how to consider closing that chest wall defect. And this could be a discussion point, certainly for the audience. I mean, I think a lot of people will agree in Gaza that sometimes you might take more risks than you would normally do in your everyday practice. They sometimes don't have the ability to just bring out stomas for certain patients because there's no stoma bags, or you might want to take the risk of giving them an anastomosis and seeing whether or not they might heal. So the thought was that we would primarily close the chest wall defect and then do a rotational flap. So that involved the plastic surgeon, Dr. Mahmoud Mahani. Now, he's the only plastic surgeon that's been at Al-Aqsa for the last 7 months. So again, thinking about burnout, thinking about the stress and pressure on one surgeon to be constantly available with an extremely high workload of plastics patients is unfathomable to us. So I haven't shown sort of I didn't have any of the pictures with the true markings for the flap, but the rotational flap was taken from just below and posterior chest and then rotated back around.
So Hani, just a question for you as a trauma surgeon trained in Canada. Is this kind of, flaps part of the training for a trauma surgeon? Should the trauma surgeon, based on what you have been basically in your training, in your practice in Oman and now in Gaza, do you believe flaps should be, surgeons, trauma surgeons should be, or war surgeons should be trained to do such thing?
Well, as a war surgeon, you need to, from personal experience, you need to learn everything. But in North America, we don't, flaps are not part of the training of trauma surgeons. We always have the backup of plastic surgery. Also in Oman, we have the backup of plastic surgery all the time. So we don't do flaps at all, unless you do specific courses yourself, if you think that the area that you're working in necessitates this. But otherwise, we don't. For war surgeons, if there is such a specialty, then yes, absolutely, they need to learn everything, including flaps and reconstructive surgery.
And that's what I would echo that. Basically, I believe anyone who's interested to go to Gaza, based on what we have seen, you should be really comfortable with all basically surgical subspecialties. I've done vascular, I've done urology, we've done urological cases, vascular cases, we've done flaps also, because again, it's you and the patient there, and most of the time you don't have the luxury or any support in terms of other specialties. We've done thoracic cases also as a general surgeon. So I believe, anyone who's interested should really try to go over some of these, basic flap in terms of, covering these complex wounds, try to do basics for urology, for thoracic, for vascular, because again, most of the time you don't have the subspecialties, because sometimes the injuries come at night and nobody can move at night. So I remember having a vascular case where we really needed an IBC injury, where he needed vascular help, and actually it was at night and he could not come because anyone moves at night, he might be targeted. So basically we ended up again dealing with these IBC and iliac artery injuries. So again, anyone who's interested or planning to go, I would strongly recommend for him to be familiar with a lot of these surgical subspecialties in order to really help the patients, rather than, as you can see, this case would have been a catastrophe. Go ahead, Bushra.
Yeah, no problems. And just as a follow-up from that, the only extra point that I'll make about Gaza is really depending on which hospital you're based at, and what the circumstances at that particular time is when you go. The idea is that these visiting international teams can hopefully relieve some of the pressure from the surgical teams there that have been working overboard for the last, almost 1 year now. But also that, potentially try not to overstep your own boundaries about what your skills and capabilities are. I mean, we were very lucky at Al-Aqsa that there were certain subspecialties available. So, we were there to help complement them or help provide them some assistance with certain cases, but not necessarily there to take over or, unless they really needed us to. So again, it's just to keep that in mind, that we're there to help complement the system and help provide some relief without necessarily sort of taking over. So just for context in terms of the wound, so on this left-hand side, this is that, so the top part of the photo is actually inferior and the patient's head is here superiorly at the bottom end. This is the exit wound, and this is the flap, well-vascularized flap that we've created. And then on this right-hand side image, this is the thoracotomy that's already been sutured closed, and the flap then coming over, which we felt had appropriately low tension.
Great.
And this is the completed image here. We sort of closed it with a combination of both some non-dissolvable sutures and some staples. Now, the thought was that this area here, as a delayed procedure, he would have a skin graft over that area. There could be some discussions about, whether or not there was potential that you could have skin grafted the original defect rather than taking a flap, but because of the major chest wall defect, it was felt that this was probably a more suitable option. So 4 days later, we had a look at the flap. You can see that there's some small areas of some bruising and potential skin loss. There's a little bit of separation there, presumably due to some tension, but overall, it's still reasonably well vascularized. There was no signs of infection. His white cell count had remained normal, and he'd been on some antibiotics. The extra thing that I'll say is that almost everyone gets antibiotics. In situations here in the Western world, we wouldn't necessarily always put people on prophylactic antibiotics postoperatively unless we were thought to be treating something active. But I would say that if they had the ability to access antibiotics, the wound infection rates and the inability to provide sterile environments across the board, whether that be pre-op, intra-op, or post-operatively, just meant that you would give these patients antibiotics to help prevent any possible infections. So this is the defect that was created by the flap. I just wanted to raise a point that, like in most of our settings, people would use potentially Gelinet or some sort of Vaseline-based dressing in order to help lubricate the wound or keep it intact. Over there, there's limited availability of dressings, especially for wounds. There's countless wounds every day that are being debrided and cleaned, both in theatres and in the wound care clinics. And so he had a little bit of gentamicin-soaked gauze, again, just to try to help stave off any potential infection to the future skin graft site. There is the ability to do bloods at Al-Aqsa Hospital. Certainly, I'd never seen a CRP, but a full blood count and a biochemistry panel was reasonably easy to access. So given that there was no signs of infection, the chest drain output had remained clear, the decision was that we would progress to trying to do a superficial skin graft onto that defect site. Now, the dermatomer that they use at Al-Aqsa shouldn't maybe be fit to use, but that's the only one that they had. And you can see we had a lot of difficulty trying to get the skin graft from his thighs, and we had to take multiple passes where if we'd had slightly better equipment, we wouldn't have necessarily had so much trouble with that. But in the end, we managed to get reasonably good coverage with the skin grafts that we wanted to take.
Actually, we've tried to get some dermatomes in, and all our efforts had failed, to be honest with you. So we tried to get a new dermatome there, but again, everything has to go there, has to be cleared. And for some reasons, these things were not cleared. And that's why you ended up using this older. It's only actually dermatome that's available in the whole middle area in Gaza that actually serves around 1.3, 1.4 million people, unfortunately.
Yeah. And just to sort of get towards the end of the tale without sort of going through all of the nitty-gritty details and things, but essentially what ended up happening was he had an ongoing air leak. Surprisingly, he didn't require any oxygen supplementation. There are physiotherapists available, and they would come routinely onto the ward, do some chest physio with him, and we were able to sort of encourage him to actually get up and mobilize reasonably early on. So just to reiterate, we had put a feeding jejunostomy in. There's no actual true feeding that can occur in Gaza. There's no TPN, there's no proper enteral feeding. But what you're relying on is really the family to be able to go and try and source something that might have some nutrition, and then either blending it themselves or finding some way to be able to make something thin enough that they can actually inject themselves down the jejunostomy feeding tube and then flush it. So a lot of the care that's provided to patients, I always tell people, is actually by their family. The nursing to patient ratio is extremely high, and there's just not enough nurses to be able to care for all of the patients that were there at Al-Aqsa. I've just put one of his chest x-rays that you can see that, like his left lung hasn't inflated. The chest drain's managed apically, and you can see the staples from where we put the superficial skin graft. We did try and do some conservative management in terms of putting some pressure. I couldn't find the video that I had originally taken, but basically the medial portion of his thoracotomy wound that had been sutured, the muscle had actually given way then he did develop an infection there. So there was some purulent material that was leaking out from within his chest cavity, presumably because the chest drain was starting to be aimed apically rather than posterobasally, and so maybe wasn't potentially draining things properly. And so trying to sort of pack it and put some external pressure didn't necessarily seem to help. And so he did end up going back to theatre for a re-exploration to also ensure that there was no other ongoing leak from the lungs, that he didn't need any further debridement to try to help reinflate that lung, and an attempt to resuture that muscle to try to help prevent this ongoing leak. Again, really difficult situation. I mean, the number of patients who've had returns to theatre or re-explorations is extremely high. It's basically a miracle if you can get away with a single shot operation or a one-stage operation for a patient. And just as a final sort of aside, I hadn't heard much about him. He's probably one of the only patients that I didn't necessarily have his contact details for to keep in touch with after I'd left. But when there was some, when the IDF put out the area to be evacuated around Deir el-Balah and then leading up to where Al-Aqsa is, so block 128 and then block 129 the next day after that, you can imagine my surprise when I turn on an Al Jazeera post and find this patient there on Al Jazeera. So I'd caught up with some of the surgical teams, and basically, you know, they were happy from his skin graft that had sort of healed well. He didn't need his jejunostomy feeding tube very much. He was up and mobile, so he'd actually been discharged home. But what he did have was an ongoing air leak from his left chest. So he'd had a chest tube that had been placed there to try to manage that conservatively for the time being. And then he'd represented a few days before Al-Aqsa was told to evacuate with some signs and symptoms of a small bowel obstruction. So that's why he's got his nasogastric tube there. You can see he's holding his belongings in a garbage bag. And if you look really closely, around the other side of where the nasogastric tube is where his ICC drain is just sort of draining into an empty bag there. But, you know, I don't really know what's going to happen to him now, because last I heard, he was maybe going to the Nasser hospital. I don't know what they'll do about his ongoing air leak from his left side of his chest, but the hope is maybe eventually things will seal on their own. And just as an aside, just in terms of even following up your patients and doing ward rounds. So we mentioned before that, you know, patients who needed to go to ICU don't always go there because there's no beds. Sometimes patients will go to a specific ward. You'll go there the next morning to try to find them. They won't be there. They might have moved. They might have been moved to another hospital even without you potentially knowing. There's no easy way to keep follow-up of all of the different surgical patients. So this is a handover between the teams that change every 24 hours in general surgery. But as you can imagine, there's high likelihood for miscommunication and for missing patients, which makes things even more difficult in terms of trying to provide good post-operative surgical care. So just a few reflections that I thought I'd note for the group, which is that as anywhere in the world, you know, trauma, and in particular here in a war setting, relies on sort of robust multidisciplinary cooperation, and in particular general surgery. That here for this patient, it involved also the thoracic surgeons and the plastic surgeons, but in many other patients, it also involves orthopedics and vasculars, because there's such high proportion of limb injuries that occur. The low resource settings, the inability to access appropriate radiology in appropriate timing, the limited supplies, all factor into providing extremely high levels of morbidity or mortality that, as Dr. Osama has already mentioned, could be preventable. And what you find is that you're relying really on a good clinical acumen. So like they say to us as we're training, you know, 90% of history and examination should provide you a diagnosis, and you just sort of have to think a little bit outside of the box as to how you can maybe treat patients to your best ability. And in terms of trying to provide some continuity of care, again, exceptionally challenging in a place such as Gaza.
Well, thank you, Bushra, for this wonderful case. And I know you have so many other cases, but for the sake of time, I've tried to answer some questions that came on the question and answer, basically regarding the presence of the Humvee knives. They are available instead of dermatome, but not always. So basically, I've seen some of them, but they ended up finishing very often. You know, basically, it's a single-use item, and a lot of time you don't have it. But yeah, they're available, but sometimes not every time. The other thing about there are some comments about the faces of the patient. I'm sure you've talked to him and he was okay to take pictures of himself. But before we post this video on YouTube, we'll try to basically cover the faces for the sake of the privacy. These things, we have actually Zarina Sheikh. She is actually one of the co-author of the Lancet paper that we talked about the global telemedicine group to support surgical cases in Gaza. She's actually one of the admins on multiple WhatsApp groups. She's asking Bushra, can you please discuss how standard disaster zone surgical techniques have had to be altered because of the malnutrition and limited resources, please? So what did you do different than what you've done in Melbourne in terms of malnutrition and then in terms of limited resources? What did you do different when you used to do in Melbourne? How did you tailor your practice there?
Well, the first thing I'll say, unfortunately, is sometimes your hands are bound and there is actually no other option. So, you know, one of the other cases, if I ever get the chance to present, and there'll be many others who've got proximal stomas that require high nutrition who never got it, and those patients have died because of an inability to feed them. So sometimes the tailoring is just to try to be a little bit creative, you know, as I mentioned, maybe briefly with the patients in terms of trying to source things such as grains or soups or something. You know, even you would tell them chicken and meat hadn't entered Gaza for 8 to 9 months. There was some supplies that started entering when we were there towards the end of June. Eggs hadn't been able to be entered for the whole time either again. So that's a source of protein, but all these supplies are extremely expensive, difficult for patients to access. All the medical teams that come in have got limited supplies that they're able to take in with them. They don't know how to bring in cash to even help provide, you know, any of this extra support. So in terms of a nutrition perspective, I would say it's very difficult to tailor because there's not honestly much that we can do. Israel's tied our hands. We can't even get, you know, TPN and enteral feeds to come in through the border, let alone any basic other medical supplies for the operating theatre. In terms of other things, I suppose part of what I'll touch on is maybe this war mentality in terms of this, you know, having limited ability to access imaging modality, high pressure cooker situation in terms of the emergency and resuscitation efforts, and sort of maybe an overriding thought that if you needed to, you know, if a patient at all looked like they might have some sort of intra-abdominal chest injury, then the treatment was actually to take them to the operating theatre, you know, to try to figure out whether or not there was an injury that you needed to intervene with. The concept of sort of maybe doing diagnostic peritoneal lavage as sort of an interim method to diagnosing whether there was, you know, hemoperitoneum in order to need to progress to operative intervention wasn't necessarily favoured upon there. And again, this is probably based on the local surgeons' experiences over the last 9 to 10 months where there was just no ability to be able to have any time to make those decisions. It was life or death and they just needed to take these patients to theatre. So sometimes even when things are not a mass casualty, you still had sort of that permeating within the thinking throughout the department. And so those are probably the main things.
Thanks, Bushra. You know, I see with one of the attendees is actually Ken Mattox, Dr. Ken Mattox, the legend of trauma surgery. He's actually with us. And it's actually a great honor to have you, Dr. Mattox, and you had raised your hand to talk with you. Before we give you the mic, actually, it's a great honor to have you. This is the case where I have done the matrix maneuver to isolate an aortic injury, to look for aortic injuries. So again, we've learned so much from you. These are the left renal vein, the gonadal vein, the aorta, and the SMA were completely, mobilized with the matrix maneuver. Thanks, Dr. Matrix, and the mic is with you. Thanks for being with us.
Oh, thank you. Just a couple of comments. Number one, during my training, we had no CT scan. This was prior to CTs. For esophageal injuries, we would put barium swallows, not gastrograph barium, to see if there was an esophageal leak. Once you're in the chest, you could put water in the chest, and then in the NG tube, although it was in the proximal esophagus, push a lot of air even putting the patient in Trendelenburg so the air would go up and see if bubbles come out is sometimes helpful. A major trick you had, it looks like you resected some lung and you have a space problem. When you're doing a thoracotomy, if you will resect a rib, it is a modified thoracoplasty, and you decrease the amount of space, sometimes helping a air leak to stop. He probably has a secondary bronchus injury that still needs to be closed. I do not like to close lung injury with a stapler. I like to close them with a suture primarily. Lastly, if you have a warring blender, the family preparing a meal just puts all the food aside or part of the food aside and brings in the same thing they ate, but that's been blended. And you could put warring blender if in the feeding jejunostomy. I compliment you on having this patient alive like he is. He's fortunate not to have a neurologic injury as well. I suspect somebody is going to have to go back into that chest and either close the air leak or create a thoracoplasty. That's all I have to say, but except congratulations on getting them this far. I agree that internationally, even in the United States, the general surgeon is not being trained in all of the skills. I personally feel that the war surgeon needs to be adept in gynecology, neurosurgery, orthopedics, burns, and not even military medical schools in any country is training the surgeon to be everything. They're training them to call for all of these secondary consultants. Even in the charity hospitals in our major cities, we often do not have that luxury. Thank you for the opportunity to speak.
Thank you. It's an honor, Dr. Maddox. Hani, can you please start your presentation?
You just allow me to share my presentation?
I believe you can, since you are a co-host.
Yeah, okay, perfect. All right, perfect. So thank you all for coming, and I hope this is going to be a quick and short presentation. My name is Hani Al-Qadi. I'm a trauma surgeon from Oman. I trained in Canada, McGill and University of British Columbia in Vancouver, where I did my general surgery and then my trauma fellowship. Currently, I'm a trauma surgeon in the Sultan Qaboos University in Oman. So our mission was for 5 weeks to Gaza. Started on June 4th and ended in July 9th. This is our picture before and after, so you can see the loss of weight. That is very obvious. Osama was not with us, unfortunately, in the beginning, but he joined us later when he cleared the permissions. And we were fortunate to have him with us before we go to the north. So our initial path was from Jordan all the way down to the south of Gaza, where we entered in Karm Abu Salim or Karm Shalom in North Gaza. And then a week later, so I spent a week in Shuhada Al-Aqsa Hospital, where Dr. Bushra was practicing as well, but she came later. And then when Osama joined, we made the trip up to the north. So as you can see, the time taken usually from Jordan to the south of Gaza takes about 3 hours. We took it in about 17 hours. And also the trip from the south to the north usually takes 38 minutes, but it took us 9 hours just to cross from the south to the north. Of note, we were the first fully equipped team to reach to the north of Gaza since the start of the war in October 7th. So entering North Gaza, I mean, I spent a week in south of Gaza in Al-Aqsa. Entering North Gaza was a totally different story. Basically, complete destruction, even more than the south. Absolute destruction of all facilities. This is us in the bus going up to the north. We went to the public aid hospital there, which is a private hospital that was converted to a public hospital because of the lack of resources. And it was mainly prepared to be a surgical hospital. So it has 25 beds and 4 ORs. No other specialties are there, only us, general surgeons. In the whole north of Gaza, there was only 2 general surgeons for 9 months, for the whole time. Since October 7th, there was only 2 qualified surgeons, general surgeons. No other subspecialties were available except orthopedics and neurosurgery in 1 hospital. But no plastics, no urology, basically no other surgeons. The team there was very exhausted, especially the 2 surgeons. So our mission was to go and give them some relief. This is us arriving in public aid hospital. We were 2 surgeons, 1 anesthetist, and 2 OR nurses. Basically, we spent in the north of Gaza, we spent about 3 weeks. We performed over 150 surgeries and so over 1,000 consultations. And it was mainly elective cases because of the people there. As Osama said initially, they don't only suffer from injuries, they also suffer from the usual problems that anybody would suffer from, like hernias, gallbladders and stuff. But they also have a lot of patients with colostomies who happen because of the war injuries. So temporary colostomies were performed, and these people needed those colostomies to be reversed. So our main bulk of surgeries were reversal of these colostomies. But that also did not exclude massacres. Every week we would get 3 to 4 massacres per week. So that also hindered our elective lists. We also did a lot of medical students teaching, Osama and Dr. Zahar, the anesthetist, and myself, because they totally destroyed their medical school. They have 2 medical schools there, totally destroyed. So the medical students don't have any facilities. So they used to come to the hospital, and we used to give them teaching as well. The challenges, as Dr. Bushra said, lack of drapes, lack of equipment, electricity shortage, lack of ICU. There's absolutely no ICU in the north, absolutely none. Lack of diagnostics. So in the hospital that we were working in, the public aid hospital, didn't have any facility for radiology at all. No x-rays, no CT scans, nothing. So the patients would go to the Al Ahli hospital, which is close by. They would get a CT scan or an x-ray if we wanted, and then they would come back to us to see the cases. And as you see in the picture, they will just come with the films on their mobile phones, and then you have to go through the CTs yourself. You can get radiology reports, but not always. So you have to read your own CTs and x-rays, which was not a big problem. The patients were very malnourished in the north compared to the south, like completely malnourished. They have not had any proper diet since October 7th. Nothing of nutritional value. They only eat wheat, water, and olive oil if they get it. But no meat, nothing, no fruits, no vegetables, no food, basically. At some stage, they had to eat animal fodder because they couldn't find any food. Also, the mass casualties, as I said. Now, this is actually the picture in the south, in the Shuhada al-Aqsa, but we faced similar challenges in the north. As you can see, while operating, the electricity would just go off, and then go out, sorry, and then you would have to use mobile phones to complete your surgeries. As you can see there, as Dr. Bushra said, the patients would be rolled into the operating room on actually a bed, like no wheels. Sometimes you can just have to drag the bed across. And this is me taking consent just before the surgery. This is how the patients are in the north, completely malnourished. Kids mainly, and also elderly, women. So all kind of injuries, all kind of all ages, but mainly kids and women. So let's discuss the case so that I don't take much of your time. One of the cases that came to us in the north was a 72-year-old lady. Of course, we were operating. I was actually that day, Osama, the only day that Osama got sick in the north. He was very sick that he had to have an IV drip. So he was out of function. And then usual day, Osama would take an operating room. I'll take the other operating room. And then we will work simultaneously. That day, Osama was sick, so I was in the operating room, operating on another injury. And then I got a call that there's a 72-year-old lady with a shrapnel injury to the flank 1 hour ago. And she's transferred from the Al Ahli hospital, which is close by, because of hypotension. No CTs, no X-rays, just hypotension and shrapnel injury to the back. So I scrubbed out. I went upstairs to see the patient in the ward. Of course, there's no ICU. She was conscious, alert. Her blood pressure was 90 over 60, but she was maintaining well. So I thought there is good circulation. Her heart rate was on the upper side, given the age. I would consider this tachycardia, but she was normal. She had normal rest rate. She only received 1 liter of normal saline and one packed red blood cell in an Ahli hospital before transferring to us, and only 1 IV cannula. So primary survey, everything is intact except that the vital signs that we discussed. I felt she was under resuscitated. She had a large wound in the right flank, but not actively bleeding, and multiple shrapnel wounds on the back and the legs, both legs, but none of them seemed to be penetrating deeply. Her GCS was 15, as I said, and the secondary survey was normal. Of course, there was no X-rays and no CT scans. So what I decided, because I had to go back to the operating room and operate on the patient that I just scrubbed out of, so I told the resident to just give her 2 units of packed red blood cells and let's see how she responds. Put a Foley catheter, look at the urine output, send for hemoglobin. That's the only blood test available in the north. Hemoglobin and creatinine. That's the only blood test. We don't have any other blood tests available. So send for hemoglobin and let's see. And I went back to the operating room to finish the case. I came back 45 minutes later. She was still hypotensive. So I thought, I think we give her enough time to monitor. So we decided to take her to the operating room. So we did a trauma laparotomy. We found immediately 2 liters of blood in the abdomen. There's a large laceration of the right lobe of the liver with active bleeding. I'll show you pictures later. There was a splenic injury, multiple small bowel perforations because of the shrapnel, and there was a large shrapnel in the back. This is the liver, as you can see. This is my assistant holding the liver, and this is me holding the sponge. And the right lobe of the liver is completely shattered. This is us applying pressure. And this is a video of the lacerated liver. So you see the moment we lift the packing, gush of blood comes. So there's active arterial bleeding from the liver. With all the limited resources that we had, this is the spleen, of course, the lacerated spleen. With all the, and this is the shrapnel. See how huge the shrapnel is. With all the limited resources that we had no choice. We did a right hepatectomy. Oops. You guys still see the presentation? No. Oh, there you go. So you see, there's a we did a right hepatectomy using staplers, cautery, and sutures. With that, the bleeding stopped actually after the hepatectomy. Then we turned our attention to the spleen and we did a splenectomy. The small bowel perfs, we repaired them primarily. And then we closed the abdomen and flipped the patient and closed the flank wound after irrigation. Well, of course, we put a drain. I'm not a drain guy, but in this case, we had to put a drain because of the liver injury and the possibility of bile leak later on. Post-op course, surprisingly, she remained hemodynamically normal. Of course, there was no ICU. There's no monitored beds, just a bedside monitor that we used. So we immediately fed her. I didn't keep her fasting because she's already malnourished. We removed the drain post-op day 5 because it was not bringing much. And she was discharged post-op day 7 to our surprise. So in conclusion, massive injuries were frequently encountered in North Gaza with all the limited resources. Lack of resources was a major stumbling block, including the diagnostics. We always believed that God's hands were with us because despite all the adversities that we faced, we didn't get a lot of, in the North I'm talking, we didn't get a lot of complications. So I guess a lot of prayers would help you as a surgeon as well in such situations. Thank you very much.
Thanks, Hani. I would really congratulate you on this case. Very well done. I remember that night very well that you came to me around like 2 in the morning, tell me, well, I've done a right hepatectomy. And I'm the hepatobiliary surgeon. I was just, what? And again, I've noticed how did this patient do well after that. And as you said, we have this, all age group injuries. This lady was in her house and she got bombed, and this large shrapnels had shattered her liver. A lot of other small shrapnels had caused bowel injuries, and basically, splenic injuries. So again, for the sake of time, I will present one case, and then we'll open it for discussion. I will present this case for. This was my first trauma case in Gaza, the north. This was the north. So I've done again 2 missions, one in the south with more than 30 major trauma and around 60 or 70 other elective cases and wound care, and on in the north again around 30 trauma and around maybe 30-40 colostomies and elective cases. So this is a young 13-year-old. I want to show you his presentation when he showed up. Shrapnels, penetrating shrapnels into his abdomen. You see the entrance, and you see the only way to identify this patient if something bad happened to him, because again, this was a bomb into his house from an Israeli drone. That's what they write their name. This is name right there. You see, it's Mustafa Hana. That's the only way that you can get identifications. So they did for him surgery. They scanned him. He has, fast positive. That's a lot of blood. The patient had peritonitis, so they shifted him from Al Ahli Hospital, where they received this patient, into the public aid hospital. So this is us after doing the trauma laparotomy, and this is what we found actually. Injury and a large retroperitoneal hematoma, reflected IVC injury with multiple small bowel perforation. As you can see here, this is a huge retroperitoneal hematoma. We're waiting for the blood to be available before we exposing it, and we're running the bowel. We have multiple injuries. These are shrapnel injuries, as you can see here, from an explosive damage. So you have multiple basically areas that need to be resected or repaired. So again, this is a very, very major injury. We're waiting for the blood to be available before we do the exposure, okay? So if note, when we inserted the Foley's catheter on this patient, he had frank hematuria. Frank hematuria, and again, when you open him, you see this expanding retroperitoneal hematoma centrally located, and you have multiple small injuries in a 13-year-old kid. So Bushra, what would you expect in this? Again, blood is not available, so I can't really explore this hematoma until you have to order blood from the other hospital. So we've dealt with some small bowel injuries with primary repair, and we had waited for maybe 30 minutes to 40 minutes to get the blood available. It's 500 meters away at the Al Ahli hospital. So what do you think, Bushra? How would you do that? No vascular surgery available, and you are the only one there.
I mean, you sort of, if you're the only person there, you have to do what you can. And so I suppose if you have got the ability for the blood to come, then I would wait for that. At some point, you've got to open up into the retroperitoneum in order to be able to evacuate the hematoma. Make sure you've got suction ready and good lighting in order to be able to try to locate, exactly where the injury is. Again, these are all ideal situations, none of which might be truly possible in a place such as Gaza.
But again, you're a general surgeon. I consider myself general surgeons with GI surgery interest. So this is a pediatric case. We have a fully full of blood, so you're expecting some sort of injuries to the genitourinary system. So you have to do urology, and now you're dealing with a very major vascular trauma on this young. So we did, again, when you explore this hematoma, you have to be careful. You have to do proximal and distal control, trying your best not to just open into things. So we ended up with, I suspected early on to be an IVC injury, but this is what we found.
Injury, but actually it turned to be a right external iliac artery injury. This is the injury right here. Okay, we did distal and proximal control, and this is the injury as you can see here right there. Okay.
So this was just an right external iliac artery injury, just distal to the bifurcation. And guess what? No vascular clamps available except these two that we have to open the thoracic surgery kit to get it. And this is a pediatric case. You don't have any pediatric vascular clamps. So again, no vascular surgery. We had some time to have to wait for a 6-0 nylon to be brought from the other hospital because again, it was not available there. And this is what we ended up, doing. So we did fix the injury, as you can see here. Okay, right there. So again, we did do an interrupted 6-0 nylon.
Interrupted repair of the common iliac artery, جاي على bifurcation. As you can see, we did interrupted repair. Now we have a pulse.
So the thing that did not make sense for us. So where is the bladders? Where's the urine? The blood in the urine came from? And again, we checked the bladder; it's fine. And having this injury right there, so you expect basically the ureter is next to it. And we asked early on, we did explore the ureter. There was nothing there, but we asked the anesthetist to give some Lasix out of the diuretics, and actually you start seeing through and through urethral injury. So again, pediatric case, major vascular injury, and now another urological injuries. I had to wait for almost 2 hours to find a double J, so I can do the urethral repair over a double J. You can see it right there. It was an adult double J. That's the only thing that they have. So again, vascular injury, small bowel injury, urethral injury, you see here, this photo here, I just made it with the type of needle holders that I'm using to repair the 4-0 vicryl. We use 4-0 vicryl for the ureter. So again, no fine vascular tip you can use to repair. So thank God this patient did well, and this is him 2 days after the surgery explaining to me what happened, that he had basically a direct hit by a drone inside his house in the north of Gaza. His name is Mustafa, and this was taken by his permission. He did explain everything. He went in Arabic. So again, I have so many other cases. For the sake of time, I think we should stop here. So many cases of pancreatic injuries, bowel portal injuries, that I think we should really keep doing these webinars to learn from everyone and basically to basically help the people of Gaza, try to be an eyewitness of what's happening there, since again, that Israeli is preventing any international media coverage inside Gaza, and also recently actually had also closed Al Jazeera, offices in West Bank. So again, they're trying to really hide what's happening, but we should be a living eyewitness for what's happening there. So there's Dr. Muhammad Bawazir. He wants to talk. I will get him to talk. I think Dr. Muhammad also was a visiting surgeon to Gaza. Dr. Muhammad, the mic is with you. Muhammad?
Assalamu alaikum.
Walaikum salam.
I did have a question. I just would like to congratulate you. Thank you very much for sharing these cases. It's been an honor and a privilege to see these cases, and hopefully we'll have a chance to go and volunteer some of our work. Thank you very much for organizing this webinar.
Thank you.
Thanks. So again, I believe one more time is I just made this proposal to do a consortium for every general and trauma surgeon who visited Gaza, and hopefully we can really pool our data in and try to basically maybe get something published down the road of what kind of injuries we have witnessed. Again, I believe the best one to talk about what's happening is the actual surgeons from Gaza. But again, with their limited internet connectivity, with their limited time and limited resources, I don't think it's the time for them to come. But hopefully down the road, we all should sit down and learn from them, because we've heard so many cases for many really horrific situations where a surgeon would do 24, 25 laparotomies per night with this number of mass casualties. If you guys remember, on October 17th, the Israeli army actually pumped Al-Ahli hospital, or the Baptist hospital. And in 1 hour, they received more than 500 casualties, both martyrs as well as injured. And you would guess no healthcare systems in the world would be able to cope with such large number of injuries. And everything happens with the whole world is watching, unfortunately. Usaid, do you have any comment? Usaid? Okay. We'll get Tanya to talk. Tanya, thanks for being with us. The mic is with you.
Thank you so much, Osama, and thank you, Hani and Bushra. These are phenomenal cases and phenomenal surgical interventions and saves. And I appreciate you all for doing this, because I can't imagine also how dangerous this is for you, as it is for our surgical colleagues that are still in Gaza, who don't have the luxury of leaving at this time. Osama, a question for you, actually a question for everyone, but many of my kind friends and colleagues from around the world, but also from the United States, and Hani from Canada as well, where I trained and grew up, they're on the webinar, and I'm wondering, what could we do as American surgeons right now if we, it's hard for us to go to Gaza, for example, but what can we do right now to support the work that you're all doing, to support our colleagues in Gaza, our surgical colleagues with the work that they are doing? What do you think would be the top one thing, or the top three things maybe that we could be doing as surgical societies, let's say, in the United States? Thank you so much to all of you. I appreciate you all.
Thanks, Tanya. So Tanya, I believe, the number one thing that should happen, and we all push for it, is an immediate ceasefire. The war has to stop. This continuous massacres that's happening on daily basis should really stop. And unfortunately, this is happening with, let's say, some sort of cover from the US government, because we all know and believe that the US government can stop these massacres if they want. and because keep supporting Israel with these bombs, attacking these civilians and innocent people. Again, that's an eyewitness from me for 2 visits. Bushra and Hani and many others have testified everywhere that what we're seeing is just civilian casualties. We never see any militant, basically, movements in the streets in Gaza or even in the hospitals. So an immediate ceasefire to start with. Now, the situation right now, to be honest with you, is much, much worse than what we had when we left Gaza. Because, for example, in the south, where most of the populations are, for the last almost month, there's no medical aids have entered Gaza at all. So people now are operating without surgical gowns. They're operating without surgical drapes. And I posted a video on my Instagram account showing Dr. Rad Al-Arini, that the thoracic surgeon that Bushra worked with, operating on a complex thoracic injury without gowns, without drapes, only with the bare gloves. He's operating on the chest. And actually just yesterday, Israel had pumped the Ministry of Health stores. There were like some limited, supplies in Rafah area, north of Rafah, and people were trying to go there to bring these supplies out of the stores, and they pumped it. And 3 of the Ministry Health people have been killed, and the head of pharmacy there, Dr. Zakari, the one we were dealing with to tell us what's needed in Gaza, actually have been injured, and he's now at Nasser Hospital ICU. So I believe this is, again, we keep talking and talking and talking and showing the world that this has to stop. And again, I only thing we can do just keep talking. No medical aids have entered Gaza, mainly South Gaza. Let's be specific, for the middle, South and Middle Gaza for the last 1 or 2 months, and people now are operating without any supplies. Even normal saline, a normal saline is actually have a shortage in it. And this is a man-made, intended things. You can allow and get things going on. I can't understand how we are all just watching people operating without surgical gowns and surgical gloves and surgical drapes. Now, aside from antibiotics, aside from blood tests, aside from so many other things that they have intentionally prevented to get into Gaza, unfortunately. So I think keep talking, advocacy about what's happening, trying to push your representative in the States, our government in Jordan, try to push and pressure Israel to get these medical supplies and medical aids. Unfortunately, the situation on the ground is that things basically limited numbers of individuals can go, healthcare individuals can go into Gaza. And if you are of Palestinian origin, to be honest with you, you can't get into Gaza. So the WHO, or at least the Israeli kind of basically instructions, if you are third generations Palestinians, basically they won't get you the permission to go into Gaza. So again, the number of volunteers have decreased significantly because of this rules. And again, only 10 people, healthcare workers, can get into Gaza every week, and 10 people can get out. Compared to the situations before the Rafah crossing border had closed, there are so many others. My Instagram account is Dr. Osama, OSAMA.Hamed, HAMED. That's where I posted the video of Dr. Al-Arini. Hani and Bushra, you want to comment on this?
Hani, you can go first.
Hani.
Well, thank you for your Tanya, for your offer to help, and I'm sure a lot of doctors are interested in helping. Spreading the word is very important of the situation in Gaza, because people are with time, people get accustomed to the situation, and they get tired or fed up of talking about it. So if we can keep talking about it and spreading the awareness of what's happening to the innocent people there, that's one way to do things. As a professional, you can also do like some kind of an online platform for the medical students. We're working on this now in Oman, where we are going to we're performing recording online lectures, and we're going to put them on an online platform so that the medical students can access, because they don't have any form of teaching over there. Also, if you are available, the doctors there, they do have WhatsApp, so you can, provide some kind of an online support to them in terms of surgery opinion or suggestions. But the main thing, all these are excellent initiatives, but it won't work without equipment. There is absolutely a dire need to get the equipment in Gaza and stop the war. And that's the main thing.
Bushra?
Yeah, thank you, Tanya. I think your question is basically a reflection of what a lot of good humans are probably asking themselves, not just even within the healthcare or medical field. I think actually a lot of the work that needs to be done is within our own circle. So, what the people in Gaza would tell us and what we have now told the world is they need us to make the war end. So not just to be able to try to get medical aid and supplies in. So how can that really happen? Well, that requires a lot of pressure from community, pressure onto government, and pressure onto institutions. So you mentioned a little bit about medical colleges or organizations. Again, most of these across the world have been completely silent or have refused to sort of partake in trying to either provide statements or care. So I think part of what we do in terms of advocacy is trying to work and tackle on that as one aspect in terms of our colleges, but even within our own spheres of our circle. So ensuring that people who are sympathetic are actually progressing towards action, and people who are completely apathetic to try to work on them to becoming a little bit more educated and potentially then lending their voice to be an advocate for it. So I think, part of it is in terms of grassroots and working within our own spheres, but part of it is also a reflection of what we can do in terms of our medical organizations. And that's also incumbent upon us to involve government as well.
Thanks.
Thank you so much.
Tanya, want to comment?
Just thank you so much to the three of you.
Tanya,
I really
I know
appreciate
you're
it.
doing some research on interviewing surgeons coming from Gaza in the United States. Can you please tell us exactly what you guys have found so far, and how many interviewed so far?
Sure, absolutely. And in fact, I have my colleague, Dr. Diane Haddad, who's on the webinar as well. She's helping together with our colleagues at the University of Chicago School of Law Global Human Rights Clinic. So in part, it's a surgical study. In part, it's also it's a human rights study. But what we're trying to do, and Osama, you've been instrumental in this, is to do a combination of qualitative interviews with surgeons that have been in Gaza or surgeons from Gaza. But as you mentioned, it's very hard for them to get internet connectivity, but to kind of create a trauma registry of injuries and wounds that people have been seeing in Gaza, to understand what the three of you have alluded to understand how can we take care of these patients in the best possible manner, knowing that there's dramatic restrictions of supplies. How do we do, it's basically damage control surgery on every organ system with what is available in Gaza. But also more importantly, what our colleagues and leads at our professors of law at the University of Chicago, what they're interested in is more sort of the systematic injury patterns that people are experiencing, overlapped and on top of the systematic human rights violations such as mass starvation or malnutrition. In particular, actually, our colleagues are interested in the effects of the war on pregnant women that have to go through childbirth, and also neonatal care, because that's not covered a lot. And as you said, it's hard to get any medical or surgical information out of Gaza because there's no media coverage there. So I'll let maybe Dr. Haddad, if she wants to comment, but one thing we were hoping to do, Osama, and we'll talk to you about this, and Bushra, Hani, if we could do the same with you, is having sort of like, how do we create a prospective trauma registry of injury patterns that you're seeing, and having almost a checklist of important data that surgeons can collect prior to even going into Gaza, so that we can all harmonize the variables that we're capturing, even the video recordings that you have, Osama, that are so beautiful and so important. And then how do we collate all that information together to make a repository of injuries and information about these injuries on the civilian population? But I don't know if Diane, you're able to comment, or you've put your hand up, or not to put you on the spot or anything. But
Yeah,
thank you, Osama.
She's on the spot now. Diane, would like to hear from you.
Thank you all so much. And it's just so inspiring and amazing to hear your stories and your resilience and the work that is being done by the local surgeons there. I can't put it more eloquently than Dr. Zackerson, who has been such a leader on my end and part of my journey, and for so many people in thinking about this. But I think, as Tanya said, I think the way that the human rights lawyers that we're working with and they look at this problem a little bit differently. We as surgeons are so we focus on the patient in front of us, and we focus on taking care of the injuries and thinking about the injuries specifically, while their perspective is so much bigger and their whole entire perspective is zoomed out. So when we met with them, had a lot to say around how you document and how you take those pictures, and how we like taking pictures as surgeons of the hole in the iliac artery and the vein, and we want to see the IVC injury and the aortic injury, and that's what we come back and speak about in this incredible forum. But from a systems perspective, and from turning this into the human rights case as to why this matters, and as you said, why a ceasefire matters, and why bringing an end to the suffering at that level matters. So we're working on kind of not only documenting a lot of this through interviews with surgeons, but also, before people go and they travel, like, these are the things that would be helpful to the people who are making the human rights case and speaking from a different perspective on trying to end the atrocities. So that's I think, beauty of some of the work that we're doing, and hope to be able to disseminate some of that to people planning on going to Gaza, kind of moving forward.
As you were talking, I'm showing some pictures of, again, that's what I've learned myself, that you have really to try to provide a whole story for the thing to happen. So I've learned from this. I'm have these videos and pictures, as you can see, so many cases out there that we can go over and over. But I believe, for the sake of time, we want, and hopefully we make these webinars on a bi-weekly or even a monthly basis. So basically, we keep talking until this war ends. This war has to end. And hopefully very, very soon, because again, the suffering is humongous. So I'm gonna there's Amir, he wants to talk. Amir, you raise your hand. Go ahead, please. Can you introduce yourself first? And
my name's Amir Afan. I'm a trauma surgeon from the United States. I was able to go to Gaza in March for a 2-week mission. So I appreciate you guys putting this on. I think this is great. And it's
Amir,
important.
you are going to be our next speaker next week. Get ready.
All right. So I would echo what you said about the supplies. That was really, truly shocking to see. At the time when we went, we took a lot of things with us. Each of us took maybe 10 suitcases of supplies, everything from vascular instruments to even I had a whole suitcase of lap sponges, because they didn't have sponges at the time. And so now that, with the restrictions, now people cannot bring in supplies. So I can only imagine, how dire the situation is from a just surgical supply standpoint. One thing I was going to ask you guys, if you could share your experiences. One of the challenges we faced was these complex cases. When our 2 weeks are over and we were leaving, the sign out and the post-operative care and who's going to follow these patients, that was tremendously challenging, because many, surgeons were displaced or had left. There was obviously a huge lack of local personnel. So, that was one of the challenges, especially with complex cases that we did. Can you share your experiences, kind of how, when you left, what happened, and follow up or the lack thereof?
Hani, can you answer, please?
Yeah, so thanks a lot, Amr, for your efforts, and I hope you continue your noble deeds. Actually, we still are in contact with the Palestinian surgeons, especially the residents that worked with us. Immediately after we left, we continued talking to them, because when we left the north, we went down to the south, and we spent 4 days before we leave Gaza. So during our stay in the south, we kept on calling them back and forth and texting them back and forth to follow up on the cases that we have talked about. We have operated on. Some patients actually still contact me. I just had a patient who contacted me because he has some sort of short bowel syndrome, because he had a massive loss of small bowel. So some patients actually contact us directly on our WhatsApps. We give them also some kind of whatever support we can give, and whatever advice we can give, and to direct them to the proper places that they should go. But the main thing is that the local surgeons there are very, very diligent, and they are just superhuman beings. And through them, we do our follow-ups with the patients that we have operated on.
Okay, for me, Hamza is, I took all these critical cases. I took their personal phone numbers, especially their families, like brothers, sisters, mother, father. And for myself, I stayed with them until now, actually. Been in contact with them, asking me about post-operative questions, post-operative care, sometimes asking for even some helps. For example, I did a duodenal injury for one patient, and we did a right hemicolectomy for his brother from a mass casualties. Their place was basically bomb. So they asked me actually to send them, sandals. They don't have sandals. So they said, if anybody is coming to Gaza, can you please send us sandals? Because again, the IDF or Israel have prevented or did not allow any shoes or sandals to get into Gaza for 9 months. And I'm sure some of you guys have seen some videos. So I've kept contact with almost all my patients myself. And as Hani said, with the local surgeons there were very helpful to give us some follow-ups if something happened. Bushra, what's your experience in continuous care after leaving with these cases?
Yeah, I'll just reiterate what you've both said, which is there'll be certain cases in particular that you'll be much more attached with. Either you've, reoperated them multiple times. So I've got a 14-year-old boy who's got 2 stomas that's waiting, to be able to get some future operation somewhere. Another 17-year-old boy, like some other of the key cases that I've done. So, I mean, contrary to what people might think, most of the time here in private, when you're working, you might give patients your own number, but certainly in the public system, you wouldn't be expecting patients to contacting you personally, but the situation requires different perspective from when you're in Gaza, especially as Dr. Osama has just mentioned. Sometimes you can help them in other ways, and you do feel a certain attachment to them because of that. And I will just reiterate, like a couple of points that there's no such thing really as good, there's not continuous clinics for patients to come to for them to get ongoing care. Like, sometimes they might present to a different hospital, sometimes they might not present at all. So true continuity and, what we would consider excellent documentation doesn't necessarily always occur. And the very last point, someone did mention, there was a few comments made about obviously patients' photos and names and things being included. And I tried to maybe think a little bit about that. We do try to think that we want to keep the honor and dignity of these patients when we're trying to present these cases, as well as when we're also talking about things online. But to some degree, we've taken their consent and we try to make sure that the information that's presented doesn't necessarily put them at risk or portray them in a certain light. But ideally, the message is that from education. So if there's been anything today where the patient's intricate details have been mentioned, we'll try to make sure that that's not easily available online outside of this sphere.
So we have also Sharif. Sharif wants to talk. He raised his hands. Sharif, can you introduce yourself and tell us what you guys want, what you want to comment? Sharif.
Hello, I'm a surgeon from Nigeria.
Yes.
I've been trying to see whether I could come for a month or two, but the only place I tried to apply, I wasn't chosen to be among those that come because they said there are many others. Are there only ways for me to come?
So I have actually placed a very nice post, had almost like more than 10,000, shares on my Instagram account. I just sent it to you. It's called Volunteers in Gaza, where there are like maybe 12 or 13 societies, NGOs that actually get people into Gaza. So I just put my Instagram account there, and you can reach there and find out exactly what other, there are so many NGOs that send people to Gaza. And then last, we'll get Adam Lee. Adam Lee is a trauma surgeon. Can you please introduce yourself and comment, please?
Thank you so much. My name is Adam Lee Goldstein. I'm the head of trauma surgery at a hospital in Yaffo in Israel. And I'm a co-director of Operating Together, which we've trained and we continue to train hundreds of Palestinian and Israeli surgeons together in trauma training. I just want to say you all are outstanding and doing amazing work. My question is, and it's a difficult question, but if you look at the most human level of what our job is doctors, and really, to preserve humanity, if there was a line that was able to help treat the Palestinian civilians in a field hospital on the border or in actually Israeli hospitals, would that, would the Palestinian community, from your eyes, be open to that? Would it be logistically and technically? It's very easy because it's been going on for decades. So, I've been pushing for that in the highest levels for months, and I'm still pushing for that. And I just want to get y'all's standpoint or a viewpoint on that.
Well, thanks, Adam, for this question. It's not a hard question at all. It's a very easy question. And I think the answer is yes, definitely. Again, as a human, we always want to save lives regardless of whatever lives. Actually, as our religion, as in Islam, if you have an injured, basically, fighter, that one who's fighting you is injured, you should take care of him and not let him die. So that part of Geneva Conventions, part of our religion as Muslims, and part of anybody else. So I don't think the Palestinians would have any issues. But unfortunately, the Israeli army or the IDF had blocked all borders, entrance and exits to Gaza. And as we speak, there's more than 14,000 injured who actually need care outside Gaza. I have basically supervised many of these cases where they need to be emergently evacuated, cancer patients, pediatric cancer patients, a lot of patients with chronic diseases, transplant patients, and injuries, amputees, basically need to be transferred outside Gaza for care, and basically the Israeli army is not allowing this. In addition to that, I myself have been involved with 2 big donors who are ready to deploy field hospitals inside Gaza. And for the last 6 months, no real progress to get these field hospitals in. So I believe the Israeli basically army plan is to make Gaza is unlivable and basically a place where people cannot live by destroying all hospitals, preventing medical aids to get in. But I believe if they want to take care of the injured patients, we have no problems at all. Actually, again, what matters at the end of the day is humanity and human lives. With this, I would like to end our session for today, and hopefully, basically, we get this on bi-weekly or even once monthly webinars, and we'll try to get things more organized for the people of Gaza. Thank you very much again for everyone who attended. And Bushra, Hani, one final word, please.
Bushra, go ahead. Ladies first.
We've had an hour and 40 minutes of word. No, thank you, Dr. Osama, for bringing us all together, and thank you to everyone for joining us online. I think, as what we've been trying to iterate is that we keep speaking up, we keep trying to spread the word, trying to get more people to advocate. And one day, hopefully sooner rather than later, the war will end.
Thanks. Hani?
Yes, thank you very much, Osama. Thank you for Dr. Goldstein for your comment, and I echo Osama that the Palestinian people, talking to them, they actually would not mind at all. Actually, one of the medical students, his mother was receiving cancer care in Israel, in the Israeli hospitals, but she could not go to Israel to continue her cancer care, and unfortunately, she metastasized because of lack of chemotherapy. But the Israeli doctor in Israel was actually contacting them on a regular basis to make sure that she's okay. I mean, or to follow up on her case. So as Osama said, they would never mind at all any kind of help. We're all human beings, and it's about humanity, not about countries or religions. Thank you all for attending, and it's been a long session, but I hope you guys have had some benefit from this, and I hope this continues, and I hope this war ends. Thank you very much.
Okay, final comment about with Usaid. Go ahead, Usaid, please. I know you were babysitting.
Hi
your
guys, sorry.
little girl.
Yeah, I was taking care of my daughter. Thank you so much for the always inspiring like webinars. Dr. Sam has been instrumental to like leading this, and not just webinars, but also doing the work on the ground. I think the trauma registry idea is amazing. Well, we had issues. We worked on something similar with the Lancet paper, just doing a case series, which is smaller work. We had a lot of issues with like follow-up because pretty much all the patients either died in the hospital or lost the follow-up because there is no outpatient follow-up, and quite frankly, some patients were abducted and they were like documented by the patient themselves after they were released. So that was unfortunate. The other thing I want to mention, the surgeon who was leading the operative management, like the general surgeon at Nasser Hospital, who happened to be my cousin, Khalid, is still abducted by the Israeli army. He was with Dr. Osama initially through the telemedicine group chat. He was leading those operations, discussing with a team of international surgeons from a lot of countries, and eventually he was abducted, and he's still abducted in over prison. So I think we have a duty as surgeons or surgical trainees to call for his release as well. I want to comment on Dr. Adam Goldstein as well. I mean, I'll give you an example. My own dad, who passed away, he needed a knee replacement. That was before the war. That was in 2000, I want to say 17, 18. And so he had, like his knee is like totally destroyed. So he needed like total knee replacement. He's a doctor who was actually one of the directors of the European Gaza Hospital, apolitical at all, which is rare in Gaza. He was denied, his permit was denied. So he wanted actually to go to get treatment because there was one of the Palestinian surgeons, orthopedic surgeon, was based in, I believe, Jaffa. And, he knew him and he wanted to go there to get treatment. So his permit was denied. My aunt, my own aunt, had endometrial cancer, and her permit was denied, and she died from metastasis. So unfortunately, I mean, a lot of patients, they need treatment. They wanted to go really anywhere. It doesn't matter. They don't care, because a lot of people historically have worked actually inside the 48 lands and wanted treatment, but unfortunately their permits denied. So I think the biggest thing we need to work on, even as Israeli surgeons, if we believe in humanity and we believe in addressing the root cause of things, I think we should also, pressure our governments to also stop this violence, because we know as doctors, prevention is more important than treatment. And that's all what I wanted to share. Thank you.
Thanks, Usaid. Thank you, everyone. By this, we will finish our basically webinar, and hopefully we can do a bi-weekly or once monthly based on everyone availability to get everyone involved who has been to Gaza to share their experience. Thank you very much. Thank you, guys. Thank you.